Let's begin with the clinical vignette. A 30-year-old male obese person comes for doctor visit due to chronic complaint of heartburn after meal, which worsen on reclining and improve on sitting or standing position. 24-hour pH monitoring with impedance show decreased pH. If this condition is left untreated, which of the following damage will happen to this patient? Now I'm going to discuss about the GERD, which is a gastroesophageal reflux disease. So gastroesophageal reflux disease is basically the reflex of this gastric content into the esophagus, and it is the most commonly due to the relaxation of transient relaxation of this lower esophageal s- sphincter. So the other causes of the gastroesophageal reflux: incompetent lower esophageal this sphincter, gastroparesis, and hiatal hernia. So the patient present with heartburn that occur after 30 to 90 minutes after the meal. Heartburn worsen with reclining, reclining position, and it improve with antacid, sitting, and standing. Regurgitation of food, dysphagia, difficulty in swallowing, chronic cough, globus sensation. Globus sensation is basically the feeling of lump, feeling of lump in throat, in throat, and morning hoarseness. The diagnosis of the GERD is primarily clinical. 24-hour pH monitoring and impedance is most accurate if the diagnosis is uncertain. Most accurate test if the diagnosis is uncertain. Endoscopy with biopsy is indicated if it is refractory to the empirical therapy, if it is long standing, so long standing to rule out the Barrett esophagus, which is a precursor lesion for adenocarcinoma, Barrett esophagus, and adenocarcinoma. So what happened? So normally the esophagus, this esophagus and this junction is lined with the esophagus. This one is lined by a non-keratinized, stratified, non-keratinized, stratified, stratified squamous epithelium. So when the GERD is long standing, so when a GERD is long standing, so what happened? This non-keratinized stratified squamous epithelium is converted into non-ciliated, non-ciliated columnar epithelium plus goblet cells. So this metaplasia is known as a Barrett esophagus. So the Barrett esophagus, this Barrett esophagus is a precursor lesion for the adenocarcinoma of the esophagus. Next is the alarm symptom. So the alarm symptom is basically the patient present with blood in stool, weight loss, and dysphagia or odynophagia. It means when the adenocarcinoma is developed and it obstructs the esophagus, so obstructive symptoms like dysphagia will present. So other investigation, barium swallow may show reflex, and esophageal manometry may show the decreased lower esophageal sphincter tone. So the management of the GERD include first lifestyle modification like weight loss if the patient is obese, head and bed elevation at the sleep time, small but frequent meals, avoidance of the nocturnal meals, avoidance of the substance that decrease the lower esophageal sphincter tone, like alcohol, chocolate, and coffee intakes. The pharmacological management of the GERD is include if it's a mild and intermittent symptoms, then we used antacid. If the GERD is a chronic, then we have the two option: proton pump inhibitors like omeprazole and H2 receptor antagonist or blockers like famotidine. In case of the GERD is severe or erosive, use PPI first. If it is refractory to this PPI, then we have option niacin fundoplication. If the GERD is left untreated and it's long standing, it will lead to erosive esophagitis, esophageal stricture, aspiration pneumonia, upper GI bleeding, and Barrett esophagus, which ultimately lead to the adenocarcinoma of the lower part of the esophagus. Adenocarcinoma. So the right option of this clinical vignette is the adenocarcinoma of the esophagus.